Hi, everybody. This is Dr. Alice Lee. Welcome to iCubed episode number 48. Yeah. So this is 4 years of my labor of love. 4 full years. Well, you know what? I have an extra special guest today because he started with me the very first episode when this started back in 2017. Yeah, 2017. And I was so grateful that somebody that I was working with and was so nice could join me and start this endeavor with me. So I have wonderful Dr. Marc Zosky back with us today.
Thank you for having me, Alice.
Yeah, you're welcome. You look great. I love having you on Zoom because when we started, you did multiple episodes when we didn't have video. So I'm really, really happy to have you on Zoom.
Oh, shucks.
Now, since Marc hasn't been with us for a little while, Marc, why don't you introduce yourself?
So, my name is Marc Zosky again. I am currently a physician in Chandler, Arizona, and Gilbert, Arizona, at Chandler Regional Medical Center and Mercy Gilbert Medical Center. Alice and I were colleagues. I guess we're technically still colleagues because we both teach at the U of A Simulation Center in Phoenix, which is fantastic. But we were colleagues at Banner Baywood in Mesa, Arizona for about 3 years before I moved on to something different. And we haven't gotten to see each other in so long because of COVID. So this is the first time I've seen her lovely face in a year and a half.
Oh, yeah, easily. So today we are going to talk about a case I had last year. So a year ago in 2019, I went over to Seoul, Korea for an international conference of emergency medicine. I actually had lunch with Judy Tintinelli at that conference. Anyway, after 5 days or so, I had to come back, unfortunately. But I went from Seoul all the way to LA, right? So then, of course, the dreaded call overhead, right? Is there a doctor on board? And around this time, I'm about right here. So I kind of just waited, and just to see if anybody answered. Yeah, exactly. But, there was nobody who answered. So I felt compelled to ask the flight attendant if anyone had responded, but no. So she walked me down the aisle towards a small kitchen area. And so I show up at the kitchen area, and there's a male, a 42-year-old male, laying on the floor in the little kitchen area, and there's a female who's sitting nearby him, and this is a Caucasian male. So I step in, and he's actually alive. He's breathing. And this is the clinical history. So I find out he's a 42-year-old male from the U.S., actually, and returning from Seoul back to U.S. He was complaining of chest pain. All right, Dr. Zosky, now what?
The most unsexy vanilla complaint that we see every day in the emergency department is now going, ah!
And now we are 30,000 feet in the air. So, Dr. Zosky,
yes, ma'am.
What would you do? Literally, what would you do? This is a scenario.
So I think initially, you walk over, you introduce yourself.
Of course.
You tell them your specialty, and then ABCs, take a quick history. Is he talking? Does he have good pulses? Is he diaphoretic? And then once I would get my primary survey done like that, I would be, sweating myself looking at the flight attendant going, what do we have?
Yeah, that's excellent. So I get a little bit more history from him. He's talking to me. He's laying there. He's not in distress. He's not diaphoretic. But he's saying he's having some substernal chest pain. Okay. And he's just finding it difficult to describe, and I'm sort of interrogating him like I always do and try to get a better feel for what his complaint is. But he couldn't describe it as a pressure. He couldn't describe it as a heartburn. But we did just have a meal just a little bit before this, so that was always in the back of my mind when I was thinking about differentials, right? So what would you be thinking at this point? What differentials are we considering here?
I mean,
in
I
the
don't know
plane?
if he has ACS or PE or dissection or basic GERD or.
Yeah, exactly. All the typical things you would see in the emergency department, you would think of right away. We're going to jump right into our learning focus because this case made me think about teaching in-flight medical emergencies, okay? So as you guys know, I do a lot of research and reading whenever I do prepare for these episodes. And this one is a fantastic review article. It's in-flight medical emergencies, and it was by Christian Martin Gill et al. From the Department of Emergency Medicine at the University of Pittsburgh and the University of Pittsburgh Medical Center. This was back in Christmas of 2018, so a very recent article in JAMA. This review article was performed by a Medline search for English-only articles, and it was done over essentially a 28-year period of time. It resulted in 14,842 articles, and finally they actually chopped it down to 317 articles to use for the review. Did you know this, Mark? Almost 4 billion people fly every year worldwide.
Mm-mm.
Yeah, that's a huge number of people. And the estimated IMEs, or in-flight medical emergencies, was approximately 1 in 604 flights, were 24 to 130 IMEs per 1 million passengers. Diversions occurred in approximately 4.4% of IMEs in this review. Most common IMEs are syncope or near syncope, 32.7%, GI complaints, nausea and vomiting, 14.8%. Respiratory complaints were 10.1%, cardiovascular symptoms about 7%, and cardiac arrests 0.2%. Yikes. So it's good to know a little bit about the pathophysiology that's different on the airplane. So commercial flights cruise at about 30 to 40,000 feet. And the cabins are usually pressured to about 5,000 to 8,000 feet. At 8,000 feet, volumes of gas in enclosed spaces expand by about 30%. And then the lower partial pressure at that altitude means the oxygen saturation in a healthy individual decreases from about 97% to 93%. Most U.S. airlines actually contract with third-party entities to provide ground-based medical support. The process is the flight attendants will notify the pilot in command, who then will establish radio or satellite telephone contact with the ground-based medical support in the airline operations center. Now, this is relevant to us, the medical volunteers' role. So generally, believe it or not, we're not really required to have proof of our qualifications, although some airlines, I think, do. Obviously, this is self-evident. You should not be under influence of alcohol or drugs if you're trying to help. Nearly half of IMEs were attended by physicians, 25% by nursing or other medical persons like EMTs. About 25% of the IMEs were attended to by just flight crew. Now, the ground-based physician usually makes the final recommendations about the care of the patient. Whenever we think about in-flight medical emergencies, there's always legal and ethical considerations, right? On domestic flights, this is very reassuring. In this article, in the U.S., the Aviation Medical Assistance Act of 1998 protects the passengers who provide medical assistance from liability, except in cases of gross negligence or willful misconduct. So that really does reassure me and helps me decide to go ahead and help,
Helps you hit your call light a little faster.
So this really is a reassuring, right, to me. It should be for all physicians, really, that unless you're grossly negligent, you're going to be fine in terms of the liability if you volunteer to help. In fact, this is even more helpful. There's only been one case of a physician sued for assisting an IME, and it was dismissed without a hearing. So
pretty good. Good odds.
Yeah, exactly. Yeah, exactly. In terms of legal and ethical considerations on international flights, this is a little bit more of complicated, and honestly, it's quite variable between countries and continents. There's varying indemnity and immunity laws from country to country. For instance, U.S., Canada, England, and Singapore, there's no legal duty for you to assist on planes. It's really a volunteer role. But Australia and multiple EU nations require the physician to render assistance during an in-flight medical emergency. Imagine that you have to help them.
Hmm.
I think, though, this statement is helpful from this article. Considering existing legal protections and international requirements, medical assistance rendered by a capable physician is of little personal legal risk and is supported by experts in aviation medicine. Now, I didn't know any of this when I tried to help. I just felt compelled to do so, and that was more just, we're physicians and we just have a natural tendency and compulsion to help in
I
medical
think
emergencies.
and I think most of us would. I don't think we'd be hiding out of fear of liability.
Yeah.
You are the best person for the job. I mean, that's actually got to be quite a terrifying thing if someone is truly sick and the flight attendant is just relaying recommendations from a ground command. That would be real. That would be very hard.
Good point. Now, in terms of diversions, the pilot in command is responsible ultimately for decisions about aircraft diversions. I mean, it's a very difficult decision, very expensive decision. The estimated cost for a diversion is anywhere between $20,000 to $725,000 per diversion. Now, there are certain cases that is really obvious that you have to divert, such as cardiac arrest with ROSC, new stroke symptoms. But most are not so clear-cut in terms of diversion, even in cardiac arrest patients. It can take greater than 30 minutes just to land to a new destination. So is that going to help with this particular case? And in a failed resuscitation, it actually may not be best for the family to go to a different city than the patient's, home, right? Here's another article I poured through, and I think it's just a fun, interesting article to see more of the characteristics of the patients that have IMEs. This was Drew Peterson et al., and also the Department of Emergency Medicine at the University of Pittsburgh School of Medicine in Pittsburgh, and then the Department of Emergency Medicine at the Brody School of Medicine at East Carolina University, Greenville, North Carolina. This was a New England Journal of Medicine article back in 2013. This article says there's 2.75 billion passengers that fly on commercial flights every year. Well, this is from 2013. The previous article was from 2018, so lots more people flying by 2018. There's in this study, they looked at nearly 12,000 IMEs among approximately 744 million airline passengers, so roughly 7,200,000 flights during a 22-month period. 16 IMEs per million passengers and 1 IME in about 604 flights. The ages of the passengers with IMEs, 14 days to 100 years.
What is a 100-year-old flying for?
Most common symptoms were syncope and presyncope, respiratory, and nausea, vomiting. Aircraft diversions occurred in 875 out of nearly 12,000 cases. So for this study, it was 7.3%. 36 deaths in the 11,920 IMEs. 30 of them occurred in flight. So very, very tiny percentage. Any thoughts on the articles there, Mark?
So the initial article you put up, the JAMA one that was the review article, was really interesting, and I was pleasantly surprised because they have a big table of what's available. Because I think that's after you do your initial assessment and talk to the patient, and you see, is this just a mild symptomatic control, or is this potentially something that could be quite significant? You need to know what's available. And they had like a pharmacy of medications, that's what I learned. They even had Haldol.
Yeah.
And then I was like, well, yeah, if you get someone who has significant, delirium or agitation, you need a sedative. All right. But yeah, they had quite a bit of medications to deal with an array of pathology, which I didn't realize they would have. I thought they would have like aspirin, Tylenol, maybe some epinephrine, maybe some allergic stuff, Zofran. But I mean, I think there were like 50 medications at least on the list that they carried.
Right. So the contents of these medication boxes, they're called emergency medicine kits. They really vary between airlines. There is a minimal requirement by the FAA, and we'll go through this here shortly.
I mean, they had endotracheal tubes and BVMs. So I'm like, well, I guess if you tube someone, you can bag them for an hour as you wait to land.
Okay, so as everyone knows, I have 2 learning focuses. This is learning focus number 2, and I want to talk about what tools do we have on the plane when we have an IME. So Mark was referring to these lists of medical kits on the plane. So the FAA mandated emergency medical kits is on the left-hand side of each of these, okay? These are the minimal requirements by FAA. So we've got the airway, the tape, we get a mask, IV needles, we've got a blood pressure cuff. You can spend a little time looking through that at your leisure. But this is, again, just the minimal requirement, right? So if you look at the additional content that some airlines will have, wow, this is very extensive. I mean, like Mark was saying, you've got the intubation kit, and you've got endotracheal tubes and scalpel, and even a cord clamp. But most airlines don't have OB or much pediatric supplies. Also, the FAA requires an AED. AEDs, though, are not mandated for European airlines. So if you travel to Europe, hopefully you don't have a cardiac arrest. Now, commercial aircrafts carry oxygen bottles for short-term use by the flight crew, actually, during sudden depressurization, though. So that's usually 2 liters to 4 liters per minute. And then currently, it is felt that the basic EMKs are sufficient for most of the IMEs. In terms of the ground-based medical support, this is another part of our, if you will, in-flight toolbox for us medical volunteers. So most U.S. airlines actually contract with a third-party entity to provide ground-based medical support. So these are 2 of the common ones in the country, MedAir and StatMD. Now, I know you guys are all just wondering what happened to the patient, right? So where were we, Mark?
You were so excited to be called on your leisurely flight to run over to see a patient laying on the floor, clutching his chest. So I think it was a 42-year-old male complaining of chest pain that kind of had, I think it was non-specific, hard to describe chest pain.
Yeah,
and then,
exactly.
And then we went from there.
Right,
so
exactly.
I guess get a full set of vitals. And so I forget, I didn't see EKG on the list of supplies, was there?
Well.
No way.
By the way, he says to me after I talk with him about his symptoms, he goes, I have this with me, Cardia. So this young man had been worked up for GERD back in LA for a little while. And before he took off for his Asia trip with his wife, he purchased a device called Cardia. I'm not here to promote any devices. I'm just simply telling you about this patient, what he had. So he had this device, and he put the little silvery thing on his chest. This is how it works. So he had that little thing on his chest.
That is so cool.
And then he showed me his phone. Cool, right?
Mm-hmm.
So, I don't know the accuracy of the ST, the baseline at all, but combined with the fact clinically he wasn't diaphoretic, he wasn't in a lot of distress, he was somewhat anxious, and then the EKG strip just had a very flat ST with a normal sinus rhythm, not tachycardic. I just felt like we had the time for me to continue to clinically assess him. In fact, I didn't even ask for emergency medicine kit, not because I was so brilliant. It's just I didn't even think about it because I was just sitting down right next to him. I just squeezed myself into the space in the kitchen area right next to him and sat with him. And I knew he was very anxious. His wife was very anxious and just chatted with him. And we weren't that far we were a few hours from LA. And he didn't look like he was in imminent danger. So I think my service to him was more just to reassure him and that he knew a physician, an emergency physician, was sitting with him and his wife and just chatting and listening to his symptoms and talking about life in general. So he, fortunately, I left him in that area. He was able to get back to his seat. So a few hours later, after we landed in LA, I actually ran into him at the customs line. He looked fine. He looked fine. And I recommended him, I know you feel better and you're feeling fine, but you really should go get checked out. Well, that was a good ending. So I'm happy that it worked out that way. But I really felt this was an important topic to talk about with my fellow colleagues because, eventually we're going to all face one or two or more because we are traveling people, right? Although not with COVID, I suppose.
But even the basic stuff that you go in over, like the legal, ethical issues and liability, I think some people still really did not know that you're pretty much protected for U.S.
Exactly.
You're protected.
Now, there is one discussion. There is one issue that people have talked about and wondered about, which is that do you accept perks from the airline? What do you think?
I don't think I would.
How come?
I think we're just trained. I think we're just trained, and it's the general understanding that it's our duty to help people, and it's why we got into this field, that we didn't do it for gifts or for
remuneration.
Or even accolades, but certainly monetary thing. Now, I'd be flattered if someone said, "Oh, thank you. We actually have a free first class seat." I don't know if I take it. I don't think I would.
I think people have very differing opinions, and for me, I had always felt no. I'm not going to take anything. It could be misunderstood as establishing a patient-physician relationship, and so I could be sued. If there's an adverse outcome. So when I was talking to the flight attendants, there's one flight attendant who was sort of semi-fluent, right? So I said to him, be absolutely sure to tell your supervisors, I do not want anything for this. I do not want the higher, better seat. I don't want anything.
Mm-hmm.
Please make sure that your supervisors understand. And I repeated it. A month later, I get a set of two watches.
Watches?
Yeah, 2 watches from airline. I know. So then I thought, well, what am I going to do about this? I can't give it back and I can't throw it away. And then I thought about it some more. So it's really the airline giving me remuneration, not the patient. So it's not like I'm charging a patient for my services. It was that airline was thankful for me providing services to their customer. So there's no direct relationship, patient-physician relationship. And then reading that review article even is more reassuring because really basically talking about liability being, we're very protected. So I was happy to have the 2 watches then. I gave one to my son.
So where's your other watch? Are you wearing it?
No, I can't read it. It's too small. My vision is so bad. All right. Dr. Zosky, thank you so much for coming back. I am Always going to be indebted to you for helping me start this endeavor in 2017. You've been wonderful.
And then how many more episodes are you going to make?
Well, so I have decided that we are going to close this chapter of my academic career. I really have accomplished what I wanted to accomplish, and I think that I'm going to be percolating some other ideas. I'm going to take a break, and then I will be back. So I especially wanted you to join me this episode because it's the last of the series of iCubed for 48, 4 years of iCubed. So Thank you so much.
Absolutely. It's a pleasure to be on.
All right. So folks, thank you so much for coming back this month to watch me and my guests talk about some relevant issues, which is that in-flight medical emergency. I sort of hope you don't have to deal with it, but you probably will. And so I wanted to provide you with some tools and some knowledge about what to do, what you can do, and mainly that you will be protected legally if you do volunteer to help. Once again, this is 4 years of iCubed, my labor of love, but it's coming to a close. I am percolating some ideas, and I will be back, okay? Just hang on. All right. Bye, everybody. Bye, Mark.
Bye.
Well, hello, folks. I just thought I would share a little bit more about my journey with iCubed. When I started back in 2017 with iCubed, there was this strong compulsion within me to give back to medicine, to give back to medical education, actually. I'd been in clinical practice for about 24 years at that point. I'd always wanted to teach, actually, but just could not do it, obviously, with my very, very busy practice and raising my 2 kids with my husband. But in 2016, I became an empty nester. And so I found myself having a lot more time on my hands. So I had submitted a few items to Emergency Medicine News and established contact with Lisa Hoffman. In fact, she was instrumental in bringing iCubed to life. Could never have done this without her help. And so I'm always going to be indebted to Lisa Hoffman. So thank you, Lisa. iCubed has been quite the labor of love for me that I've enjoyed tremendously. But it takes a huge amount of time, 30 to 40 hours a month probably, to go from the case to research, the slides, the recording, and then the editing afterwards to get to the final episode and the final draft. And I couldn't have done it without the gracious assistance of many of my colleagues. And along the way, I was fortunate enough to meet and record with some legendary EM educators, high-profile educators such as Amo Matu. But I think it's time to close this chapter. I really feel like I've accomplished what I set out to do with iCubed. I wanted to help, especially the young physicians, navigate between academic medicine and clinical medicine. That transition can be very anxiety-provoking and very uncertain. How would I do that? My idea was that I would illustrate the thinking of an emergency physician, the gestalt, if you will, through case illustrations and through the discussion with another emergency provider. It's almost like see one, do one, teach one, right? I also learned a skill along the way, a very valuable skill, which is to create an audiovisual product, audiovisual educational product. So iCubed is going on a hiatus. I've got some ideas percolating in here. So just hang on. I will be back after a break.